You are all welcome back to the second session for today, and we will continue with the MCQs. Now, the first question goes, all the following burns require extra fluid administration except A, burns greater than 70% total body surface area, electrical burns, inhalational injury, pediatric burns, and fourth-degree burns. So if you look at this question, usually burns, it's a condition that is associated with excessive insensible loss of fluid. So when you have a burns patient, among the most important treatment you give is fluid administration. And there are various formulas used in estimating the fluid requirements for a burns patient. Now, to estimate fluid requirements of a burns patient, we commonly use the Parkland's formula. We commonly use the Parkland's formula. And the Parkland's formula is you give the fluid requirement is 4 mils per kg times the percentage times weight of the patient times percentage burns. Now, this will give you the total 24-hour fluid requirement of a patient. And the first half of the estimated fluid, first half of this estimated fluid is given in 8 hours from the time of burns. And the second half is given over the next 16 hours. For example, if you estimate that the total fluid requirement of this patient is, let's say, 4,000 mils, for example. So 2,000 mils will be given in 8 hours from the time of burns, and the other 2,000 mils will be given in the next 16 hours. But however, you need to understand some certain points regarding the Parkland's formula. The first point is for you to know that the percentage burns, maximum that is used does not exceed 50% in the Parkland's formula. So even if a patient has a burns of 70%, the maximum amount that can be used in that Parkland's formula is 50%. Okay, if you are using 70% or more than 50%, you will be overloading the patient, okay, with fluid. So now, if you there are some other points you need to know about this Parkland's formula. Another point is in the pediatric age group, if you use only the Parkland's formula, you will not give adequate fluid to the child. So you have to add the Parkland's formula. It's modified in pediatrics. Okay, it's modified. So you must add the daily maintenance of that child. Okay. You must add the daily maintenance of that child. For example, if the formula for Parkland's, and by the way, for pediatrics, you don't use 4, you use 3 mils per kg. okay, rather than 4. If you look at the formula we said for the adult is 4 mils per kg times weight of a child times percentage bonds plus daily maintenance. So daily maintenance is an additional fluid a child will require. So that is what you need to know. And as we mentioned earlier, in our previous MCQs, we mentioned that when a patient has inhalational injury, the fluid requirement will increase because of the insensible loss will also increase. So if you come back to this question, all the following bonds require extra fluid administration except a bonds greater than 70% greater total body surface area. So this is it will not require additional fluid because whether greater than 70, whether 80, 90, 100, the maximum percentage used in the Parkland formula does not exceed 50%. Now, in electrical bonds, you have to give large amount of fluid so that the tissue that is destroyed, the muscle breakdown will not cause muscle injury, acute kidney injury. So you have to hyperhydrate and even alkalinize the urine so that patient does not develop renal failure. So inhalational injury, we mentioned that is correct. In pediatrics, we mentioned that you have to add the maintenance of that patient, okay? Then 4th degree burns has gone down to involve even the muscles and the bones, so they will require more fluid. Now, a 23-year-old man involved in a house fire sustained 2nd and 3rd degree burns to his face, anterior chest and trunk, okay? Entire left arm, perineum, and both legs circumferentially. What is the estimated total surface area, total body surface area involved in the burns? Now, you should know in estimating total surface area, there are several formulas. Use the rule of 9, the Wallace rule of 9. You use the Lund and Broders charts in the pediatric age group. You can use the rule of Palm. Now, the commonly used formula is the Wallace rule of 9. Now, if you look at the rule of 9, what is it all about? The rule of 9, the head and neck, okay? You have 9%. The trunk, anterior trunk is 18%. The back, the posterior trunk is 18%, making 36. The upper limb is 9% each. The lower limbs are 18% each. And the perineum makes up 1%. So this is how the Wallace's rule of 9 estimates total bone surface area. Now, if you go back to that question, now a 23-year-old man is involved in a house fire, sustained 2nd and 3rd degree burns to his face. Now you can see it's not the entire head and neck that is involved. You have only the face, which will give you 4.5%. The anterior chest which will give you, and trunk, which will give you 18, because we said the back is also 18, making 36. The entire left arm will give you 9%. The perineum will give you 1%, and both legs circumferentially. So you add, this should be both lower limbs, okay, will give you 18%. And if you sum off plus another 18%, it will give you, if you sum all these, it will give you 68.5%. So what you need to know is to understand how to use the Wallace rule of 9 in calculating the total bone surface area. Now, during wound healing, collagen is laid down by, okay, during wound healing, collagen is laid down by A, endothelial cells, B, fibroblasts, C, the wandering macrophages, D, the surrounding epithelium, E, none of the above. We should know that during wound healing, the cells that synthesize, collagen is the fibroblast. And this fibroblast requires presence of vitamin C. We should know this for the synthesis, for the hydroxylation of and for synthesis of vitamin C. So fibroblasts are the cells that lay down collagen. All of the following are complications of breast implant, except A, capsular contraction, B, increased risk of infection, C, breast asymmetry, D, systemic inflammatory reaction. Now you should know that breast implants, the common, if of all these options that are shown, of all these options, this is only a systemic complication. All these options are local complications that are related to the implant. So this systemic inflammatory reaction is an unlikely complication, because usually most of the implants that are used are inert. They are unlikely to cause a systemic inflammatory problems. Now, digital rectal examination in surgical outpatient clinic can be done with a patient in the following position. Now, don't forget in your exams, in the OSCE, don't forget to mention that you will do a digital rectal examination, because it carries 2 marks. Just mentioning that you do a digital rectal examination. If you have completed your abdominal examination without a digital rectal examination, that is a grossly incomplete digital rectal examination, and 2 marks are allotted to digital rectal examination in the marking scheme. So try to tell, don't forget to tell your examiner that I will complete my abdominal examination with a digital rectal examination. Okay, so digital rectal examination in a surgical outpatient clinic can be done with the patient in the following position. A, lithotomy position. B, lateral position. C, A and B are true. D, Sims position. And E, all of the above. Now, your correct answer here is D, Sims position. Sims position is the left lateral position. That is one of the positions you do a digital rectal examination. And you can see you cannot do a lithotomy position in the clinic, even though digital rectal examination in the theater, patient in lithotomy position, it can be done. But it's not the routine positioning for a digital rectal examination. But if you are doing an anorectal procedure, patient in lithotomy position, of course, you do a rectal examination. But at the clinic, the positions are one, the Sims position, which is also called the left lateral position. Two, the second positioning for a digital rectal examination is called the knee elbow position. And three, the third position is the dorsal position. Okay, so let's proceed. Which of the following is false regarding intracranial dynamics? Which of the following is false regarding intracranial dynamics? Now, before we discuss this question, you should know that the brain is a rigid structure. Okay? The brain, the skull. The skull is a rigid bony structure that contains a constant volume of the brain, CSF, as well as blood vessels. All these are in a constant proportion with a fixed intracranial pressure that is between 6 to 15 millimeters of mercury. Okay, that is the normal intracranial pressure. Now, if one of these three components increases, it has to displace the two others so that it can maintain the normal intracranial pressure. Why? Because the skull is a rigid structure. Not in the pediatric age group where the fontanelles have not fused, of course. We are talking about in an adult. Now, you need to know about the Mcqs doctrines. Mcqs phenomenon, or the Mcqs doctrine. So because these three components are in a constant proportion within the fixed cavity, this rigid cavity, an increase in any one of these components will lead to displacement of two others in order to maintain the intracranial pressure. Because if there is increase without displacement of the others, there will be increased intracranial pressure, which is detrimental. It's a pathological conditions where you will now start seeing some manifestation, some clinical manifestation of an elevated intracranial pressure. Now, this increase could either be from the brain tissue, maybe tumor, CSF accumulation, from maybe choroid plexus adenoma or papilloma that is producing more CSF, or from blood vessel rupture leading to blood collection. Okay. Now, the first option here says that the normal intracranial pressure is 6 to 15 millimeters of mercury, or 8 to 18 centimeters of water. That is correct. The relationship between the expanding intracranial mass and the resultant rise in the intracranial pressure is linear, meaning there is a linear relationship as this increases, as the mass increases, the intracranial pressure will increase. The intracranial pressure will also increase. So this is not true because it tends to balance. Initially, the curve will not be a linear curve. It will go like this. It tends to balance until the displacement exceeds this pressure that can be maintained. then it will now, it keeps on displacing, adjusting the intracranial pressure until it gets to a limit where it cannot. So it is not a linear relationship because of what we explained earlier. Cerebral blood flow depends on cerebral perfusion, that perfusion pressure and cerebral vascular resistance. That is correct. If you look at the formula, lumbar puncture is contraindicated in a patient with known or suspected intracranial mass lesion. Yes, you don't do lumbar puncture where you suspect an increased intracranial pressure. Which of the following is not a classic finding of someone with raised intracranial pressure? Now, what you need to know, if a patient has raised intracranial pressure, they can present when it keeps on increasing beyond that space, because the space is not expanding, it will start coning. It will start coning through the foramen magnum. And the classical sign you see is called the Cushing's reflex. And this reflex has three components. It has bradycardia, hypertension, and irregular breathing. So if you look at the options here, headache with nausea and vomiting, yes, is a feature of raised intracranial pressure. Respiratory changes, yes, if they have Cushing reflex. Increased blood pressure, yes. Tachycardia. So tachycardia is false because you rather have a bradycardia. What is the most common cause of epidural hematoma? Now, epidural hematoma, before we answer this question, what you should know about the feature of epidural hematoma is the type of intracranial hemorrhage that is characterized with what is termed the lucid interval. Lucid interval. Now, patients with epidural hematoma, at the initial impacts causing the head injury, they lost consciousness, okay? And that is a primary injury. They regain the consciousness, but when they have sustained injury to a vessel, that vessel keeps on bleeding and accumulating blood within the intracranial space, and to an extent that a patient develops a raised intracranial pressure and patients relapse into unconsciousness. Now that period, that interval between the first loss of consciousness and the second loss of consciousness is called the lucid interval. This is as a result of the first primary injury. This is as a result of the secondary brain injury. Now, and usually the vessel that is common, the commonest vessel that is involved in epidural hematoma is a branch of the middle meningeal artery, okay? Is the middle meningeal artery rupture. So this option says a rupture of the middle cerebral artery, false. Rupture of anterior cerebral artery, false. Posterior communicating artery, rupture of middle meningeal artery. And it's located just beneath the pterion, if you remember your anatomy. So the next question, what is the typical appearance of an acute subdural hematoma on non-contrast CT scan. We discussed this earlier when we were talking about imaging. Now, I told you that the appearance of a lesion, when you see a biconvex, okay? If you see a biconvex lesion, let's see, if you see a biconvex lesion like this, you see the blood here is taking the shape of the dura on this side, and it's also compressing on, the shape of the skull on this side, the outer side, and it's compressing on the dura, taking that shape on the other side. So it gives a biconvex, and this signifies epidural hematoma. And this is between the dura and the skull, and it doesn't cross sutural lines. Now, for subdural hematoma, they present with crescentic, that is concave in the inside and convex in the outside. That is subdural. So you can call it a concavo-convex. And this is beneath the dura, so it can cross suture line. So now, epidural hematoma is biconvex, while subdural hematoma is crescenteric or concavo-convex. And you should know, we said acute, subacute, or chronic on the image will depend on the appearance in relation to the brain tissue. If it is whiter than the brain tissue, it is hyperdense, which is acute. If it is the same as the density, is the same as that of the brain tissue, is isodense. And when it is darker than the brain tissue, is hypodense. Hyperdense is acute, isodense is subacute, and hypodense is chronic. Now, this question is asking about subdural hematoma, okay? So it says, A, diffuse intraparenchymal hypodense lesion, false. Hyperdense biconvex mass, this is for epidural. Hypodense intraventricular mass, no. Hyperdense, okay, concave mass. So it is acute, it is hyperdense, and of course, subdural hematoma. Okay, so let's proceed to the next. Okay. Where are we? Okay. Number 10. The most common cause of exophthalmos in children is A, hyperthyroidism, that is false. Orbital cellulitis, that is true. Orbital tumors. Orbital tumors are common, but infections are commoner as a cause of exophthalmos in children as compared to tumors. Orbital hemorrhage, okay? So orbital cellulitis is commoner as a cause of exophthalmos in children, please. So which of the following requires most urgent attention? Central retinal vein occlusion, okay, cataract, scleritis, central retinal artery occlusion. This will cause retinal damage, so it requires more rapid attention. Of the following occlusion, which is not considered urological emergency: paraphimosis, priapism, orchitis, testicular torsion, autonomic dysreflexia. Now, paraphimosis is when you have the preputial skin, okay, retract and form a band around the glands, okay, and it can cause severe pain, inflammation, and even ischemia. So, and this is an emergency. So the treatment for this is to do circumcision to remove that preputial skin. Priapism is also a painful, persistent penile erection, is an emergency. Orchitis is infection, okay. Orchitis, testicular infection, is not an emergency. It can be treated with antibiotics. Testicular torsion, of course, it has to be addressed and detorted within the first 6 hours. If not, patient can lose their testis. Autoimmune dysreflexia can lead to acute urine retention, so it's also an emergency. A 55-year-old man reluctantly admitted to difficult in maintaining an erection sufficient for sexual intercourse for the past 2 years. He reports being healthy. However, he has not seen a physician in 10 years. Which of the following will not suggest a potential cause of erectile dysfunction? So the question here, which is not a potential cause of erectile dysfunction? Now, you should know that causes of erectile dysfunction vary from systemic to local causes and even psychological causes. Now, there are some systemic conditions that are associated with hormonal imbalance, okay, and some metabolic conditions. There are some other local problems also that are associated with hormonal imbalance. All these are conditions that can lead to erectile dysfunction. Patients with hypertensive diseases can have erectile dysfunction. Patients with galacturia from several metabolic conditions causing hormonal imbalance can lead to erectile dysfunction. Acanthosis nigricans is also associated with metabolic syndromes like diabetes mellitus. It can also be related to erectile dysfunction. Not acanthosis nigricans on its own can cause erectile dysfunction, but rather the associated conditions it has. Varicocele can cause infertility, not erectile dysfunction, because you have the impairment of spermatogenesis, okay, because of increased temperature within the scrotum. Then eruptive xanthomas are also associated with conditions like dyslipidemia, diabetes mellitus, and obesity. And these are conditions that are known to be associated with erectile dysfunctions. About hernias, which of the options is correct? Leiter's hernia is a hernia with appendix as a component. B, incisional hernia are congenital ventral hernias. C, pantaloon hernias has both direct and indirect component. D, all of the above. Now, when you hear Leiter's hernia, please, you should know that it's a hernia that contains the Mcqs diverticulum within the sac. The hernia containing Mcqs diverticulum within the sac is termed Lita's hernia. It is Amiens. Amiens hernia are the hernias that contains appendix within the sac. So this first option is false. B, incisional hernia, congenital ventral hernia, no. Pantaloon hernias has both direct and indirect component. That is correct. All of the above is false. So our answer is C. When you hear pantaloon hernia, it has both direct and indirect inguinal hernia. That is a pantaloon hernia. Okay. The tetrad of features found in infantile inception include the following. A, sausage-shaped abdominal mass. B, paroxysmal attack of colicky abdominal pain. C, passage of bloody mucoid stool. Now, these features are very important for you to understand the classical presentation of a patient with intussusception. When you say intussusception is telescoping of a segment, usually a proximal segment of a bowel into a distal segment, okay? So it can be classified as antegrade and retrograde intussusception. It could be antegrade and retrograde. Okay, now, usually it is the proximal that's telescope into the distal. Distal telescoping into the proximal retrograde is uncommon. It is the the proximal telescoping. Now, you should know that the commonest site of intussusception is at the ileocecal junction, telescoping the ileocecal region, where this terminal ileum telescope into the colon. And this will give you a sausage-shaped mass. And on ultrasound, that is called, you see a target sign. Now, a sausage-shaped mass is correct. Paroxysmal attack of colicky abdominal pain, and the child will be presenting with paroxysms of and crying spells, and they pass a bloody mucoid stool. So they pass what is called red currant jelly stool. If you remember that currant fruit you see on this Rabina juice. So the stool will be a mucoid and has that color due to mucosal sloughing. Malignant neoplasm of the kidney, choose the odd option out, are best managed surgically. We are choosing the odd options. May have solid and cystic component, always responds to chemotherapy, always originates in an adenoma. So they do not commonly respond to chemotherapy. So that is odd. Surgical treatment is the main treatment of choice. Okay. Which of the following complications of wound healing can be controlled by the surgeon? We are talking about a complication that can be controlled by the surgeon now. Keloid formation, wound infection, hypertrophic scar formation, all of the above. The answer is all of the above, because for keloid formation now, if a patient has keloidal tendency, okay? Now, if you are excising a keloid, you have to go intralesional. If not, it's going to recur, okay? But to some extent, if not for that, if a patient has keloidal tendency, there's nothing you might do about it, except you take some measures, aside this, of course, you want to prevent recurrence. You can inject steroid triamcinolone injection into the postoperative site. You can apply silicone gel. All these are to prevent recurrence. However, if a patient has a keloid and you are trying to excite to minimize or risk of recurrence, you go intralesional. Then wound infection, to have control over wound infection, you have to maintain asepsis. Okay, there's no, you shouldn't breach the surgical cycle. You have to maintain asepsis. Okay. Hypertrophic scar formation. Usually this is seen when the wound is infected. So you have to maintain asepsis. Then patient will not develop all that. About prostate gland in a Nigerian, okay, it is unlikely to ever develop cancer compared to Caucasians. B, benign hyperplasia occur as early as 18 years, okay? It is multinodular. D, none of the above. So your answer here is D, because all these are not correct. About classification of chest injury. Flail chest is an example of life-threatening chest injury. That is correct. Hemopericardium requires thoracotomy, not necessarily. You can do pericardiocentesis. Tension pneumothorax can be life-threatening. It's life-threatening. Open pneumothorax can cause an immediate loss of life. So your answer here is B. Hemopericardium requires a thoracotomy. It's the odd one. Okay. A 25-year-old man was brought to the accident and emergency department with sudden severe, generalized abdominal pain. Okay, take note of that. Sudden severe generalized abdominal pain. Physical examination shows pulse rate of 120 beats per minute, blood pressure of 90/60 millimeters of mercury, and board-like rigidity of the abdomen, which is false. Now, if you look at this question carefully, this patient is in shock. If you have a patient with pulse rate that is greater than 90, you have a pulse rate that is greater than 90 beats per minute, and you have blood pressure of less than 90/60. That patient is in shock. And of course, you can see he has a generalized abdominal pain with board-like rigidity. That means he has peritonitis, and he presented to the emergency in shock. Okay. So they are asking for which is false. A, if due to acute pancreatitis, urgent surgical intervention is the treatment of choice. B, may be due to perforated duodenal ulcer. C, acute pancreatitis is the likely cause. Okay. D, he will require an erect chest, upper abdominal X-ray, which may show air under the diaphragm. Okay. Now, if you look at all these options, A is not correct. Why is it not correct? If it's acute pancreatitis, okay, you do not explore the patient. So it doesn't require an urgent surgical intervention. You commence resuscitation, okay, and give antibiotics and analgesics, IV fluids generously, okay, it subsides. And the first thing you do here is to correct the shock until the patient is now making adequate urine, okay, before even thinking of exploring any patient. So for acute pancreatitis, except there is extensive pancreatic necrosis that you want to debride and remove the slop, or abscess that you want to drain, and even so, patient has to be resuscitated, making adequate urine. Maybe due to perforated duodenal ulcer, that is correct. Acute pancreatitis is a likely cause, is correct. He will require an erect chest X-ray. Yes, when you do chest X-ray, you will be looking for air under the right hemidiaphragm. Now, 22, factors favoring wound healing. A, vitamin C. Yes, we mentioned that vitamin C is relevant for the synthesis of collagen. B, arginine. Okay, yes, it's a amino acid that is required for wound healing. Bilirubin interfere with it, prevents wound healing. Then you have good blood supply is required for wound healing. Concerning carcinoma of the esophagus, A, dysphagia is usually initial for liquid. B, a common cause of deaths in Nigeria. C, internal stenting is curative. D, the proximal esophagus is usually markedly dilated on barium swallow. Now, you need to understand something interesting about carcinoma of the esophagus and how it differs from achalasia cardia. They usually have progressive dysphagia and the duration is short, okay? They have progressive dysphagia over a short duration, while for achalasia cardia, it's for a longer duration. That is one. And two, you should know that for, let me just tabulate it. CA, esophageal carcinoma, then achalasia. Okay. Progressive. This can be intermittent. Shorter duration. Longer duration. Three, for carcinoma, initial dysphagia is to solid. The initial dysphagia here is to liquid. Okay, this is very important. You understand the initial dysphagia, even though ultimately they become dysphagia to both liquid and solid. Now, concerning carcinoma of the esophagus, dysphagia is usually initially to liquid, which is false, is initially to solid. A common cause of death in Nigeria, okay, that is, it's not a common cause of death in Nigeria. Internal stenting is for palliation. It's palliative, not curative. For those who you cannot resect the tumor completely, you just pass a stent to bypass the obstruction. Proximal esophagus is usually markedly dilated on barium swallow. That is the part that is above the site of the obstruction. When you take a barium swallow, there will be stasis, so it will be dilated. And this is commoner with the achalasia as compared to the carcinoma, because in carcinoma, even though the proximal part will be dilated, that is not a classical feature. You have irregularities, you have a filling defect, okay, and you have a shouldering effect. Regarding typhoid perforation, A, it frequently affects neonates. B, gas above the diaphragm may be present on plain chest radiographs. C, causative organisms, Salmonella type, is acquired by hematogenous routes. D, perforation is the result of invasion, necrosis, and ulceration of the Peyer's patches. That is correct. Okay, so A is, it doesn't occur in the neonate. It's very, very rare or unlikely in the neonate. B, gas above, so is gas below the diaphragm. So this is false. Causative organism is fecal-oral. Salmonella transmitted via fecal-oral. Perforation usually is due to invasion, ulceration, and necrosis of the Peyer's patches. That is the correct answer. Concerning perineal warts, which of the following is false? Can be treated by cauterization. B, heavy growth may be associated heavy growth may be associated with HIV infection. Now you should know perineal warts. When anytime you see a perineal wart in an individual, you should screen that patient. Not only for, you shouldn't be thinking of only HIV. You must screen that patient for HIV. All other immunosuppressive diseases can cause this perineal wart, and sometimes they appear as AIDS-defining illnesses. Okay. C can also be associated with herpes simplex virus. Okay. Then are seldom seen in homosexuals. So what is our answer here? So how is it treated? Yes, you can treat it by cauterization. Growth is associated, is true. So D is false. D is the false answer. It's common, you can commonly see it amongst homosexuals. The following modalities for treatment of Wilm tumor include A, radiotherapy, B, chemotherapy, C, surgery, D, A and C, and E, all of the above. Now you should know that Wilm's tumor has all this modality. All the modalities of treatment. About hernias, which of the options is correct? Litters hernias is a hernia with appendix as a component. I think we've answered this question before, so let me just keep it. Malignant neoplasms of the kidney, choose the odd option. We've answered this also. Okay. I think we have some repetition. Surgical causes of hypokalemia include the following, except A, biliary fistula, B, typhoid perforation, C, infantile hypertrophic pyloric stenosis, D, renal failure due to bladder outlet obstruction, E, all of the above. Now, if you look at this question, okay, all these conditions will cause loss of potassium except D. So, biliary fistula, there will be loss of potassium via the fistula. Typhoid perforation, most of the time they present with hypokalemia. Infantile they vomit, and the vomitors contain a lot of potassium. Why D, they tend to retain potassium. Gastric outlet obstruction produces the following metabolic derangement, except, as we mentioned earlier when we saw the image of GOO with pyloric stenosis, we said the electrolyte changes in gastric outlet obstruction are 1, hypochloremic, 2, hypokalemic, 3, hyponatremic, okay, 4, metabolic alkalosis, paradoxical aciduria. They can have hypocalcemia. And don't forget, in gastric outlet obstruction, Ringer's lactate is contraindicated. Please don't forget. Ringer's lactate. Don't forget, never give Ringer's lactate. It's contraindicated because that lactate will be converted to bicarbonate, which will further worsen the alkalosis, the metabolic alkalosis. Now, gastric outlet obstruction produces the following metabolic derangement, except A, hypokalemia, B, metabolic alkalosis, C, hyponatremia, D, hyperchloremia, E, paradoxical aciduria in later phase. Okay, so what is our option here? What is our answer here? From what we explained, our answer is D, because the most important don't forget, please, the most important electrolyte derangement in a patient with gastric outlet obstruction is hypochloremia. So this is an except. And this is the electrolyte derangement that, if it is corrected, all other electrolyte derangements will also be corrected. Then you now add potassium to your maintenance. After correcting potassium, then you now continue. Sorry, after dehydration has been corrected, you now correct potassium. Okay. In other words, when you correct hypochloremia, both the natremia will be corrected, the metabolic acidosis will be corrected, paradoxical aciduria will be corrected. Then you will now correct the hypokalemia. Okay, sorry for that slight interruption. So 33, Hirschsprung's disease. Now, in Hirschsprung's disease, a presentation is most commonly at puberty. Okay, of course, that is false. May rarely present in adulthood. Yes, it can present in adulthood. Dilated segments of colon is the neurologically abnormal area. That is false. So you should know in a Hirschsprung's disease, the dilated segment, okay? The dilated segment is the side that has ganglion. The side that is collapsed is the side that is aganglionic. Okay? The side that is collapsed is the side that is aganglionic. Okay? So you should know that. Then D, let's go, yes. Dilated segment of the colon is the neurological abnormal area. So that is false. Enterocolitis is a serious complication. Yes. Hirschsprung's associated enterocolitis is a serious complication of Hirschsprung's disease. Okay, parasympathetic ganglion cells are absent in the myenteric but not submucosal plexus of the colon. So this is false because the parasympathetic ganglion are present in both the myenteric and submucosal plexus. So what is our answer? Our answer is D, because this is false now. Okay, this is also false. It's rarely present. It presents it in adulthood also. It's seen, it's a congenital problem. So our answer is D. 34. An 18-year-old child presents to the A&E department with acute onset of pain, marked tenderness, with guarding in the right iliac fossa. Which of the following statement best describes the differentials? Now look at the age of the child. So when you are giving the age of the patient, when you are giving a question, please, you should take note of the age of that clinical scenario, okay? An 18-year-old girl presents to the A&E. Now, the age is what, 18-year-old, and she's a female. To the accident and emergence with acute onset pain, marked tenderness, with guarding in the right iliac fossa. Which of the statements best describes the differential diagnosis? Which of these statements best describes the differential diagnosis? Of course, if this is a male and with this age group, this is a male at this age group, of course, acute appendicitis will be your number one differential. But in females, when a patient presents with right iliac fossa pain, even within that age limit, in females, you have to look for other gynecological causes, okay, of right iliac fossa pain. So in females, you have more differentials as compared to males. A, ectopic gestation is correct. Acute appendicitis is correct. Twisted ovarian cyst is correct. Rise salpingitis, all are true. So our most appropriate answer, or the best answer here, is E, being a female. About the differential diagnosis of intussusception in Nigerian children, which is the best option? Which is the best option? About differential diagnosis of intussusception in Nigerian children, which is the best option? A, parasitic infestation. B, gastroenteritis. C, obstructed hernia. D, intestinal volvulus. E, all of the above. Now, you should now, regarding differential diagnosis of intussusception in Nigerian children, okay, your best option here will be D, intestinal volvulus, as a cause of intestinal obstruction. Okay, all these could be a differential of acute abdomen in a child, but the common one that will cause features suggestive of intestinal obstruction is intestinal volvulus intussusception. Important causes of obstructive jaundice in Nigeria include the following, except now: A, alcoholism. B, ascaris infestation. C, biliary atresia. D, tumors of the head of the pancreas. E, okay, cholelithiasis. Important cause of obstructive jaundice in Nigeria include the following, except now alcoholism will cause chronic liver disease. Chronic liver disease. It will cause liver cirrhosis. Okay. When it causes obstructive jaundice is only when there is transformation into hepatocellular carcinoma, and that is uncommon where you have intrahepatic cause of obstructive jaundice. But ascaris lumbricoides can block the hepatobiliary tract. Biliary atresia, yes, can cause obstructive jaundice, especially in pediatric age group. Tumors of the head of pancreas, very common cause of obstructive jaundice. Cholelithiasis, also very common cause of obstructive jaundice in Nigeria. Anorectal and colonic carcinoma may spread to the following area. Anorectal and colonic carcinoma could spread to the following area. A, vagina in the females, correct. B, inguinal lymph nodes. Now, anal cancers can spread to the inguinal lymph nodes, but not colonic cancer. Okay? Anal cancers can spread to the inguinal lymph node because the part below the dentate line is actually drained by the inguinal group of lymph nodes. Left supraclavicular lymph nodes, okay? Santorini plexus in females, and pancreas. So now all this is pancreas, supraclavicular lymph nodes, left supraclavicular lymph node. Now, usually, you should know that there is what is called virtuous node. When there is left supraclavicular lymphadenopathy, when an intra-abdominal malignancy is spreading to a junction where the thoracic duct enters into the jugular vein, okay? Junction of the internal jugular vein and the left subclavian vein. At that junction, you could have deposit of malignant cells, especially intra-abdominal malignancies from stomach, pancreas, and all that. Upper abdominal malignancies, they can cause left supraclavicular lymphadenopathy. So here, the one that is not correct, they say adorectal may spread to all these are uncommon. So it can spread, this is the correct answer here. A is the correct answer. It can spread to the vagina in females. Now, what you should know about this, when it advances the vagina, rectal tumor, they have rectovaginal fistula. And you see this patient passing feces via their vagina. Okay. In the management of liver abscess, patients should receive hepatitis B immunization. B, amoebic, what is this? Presbyterian test is useful in the diagnosis of amoebic liver abscess. C, open drainage of the pus is the best option in pyogenic abscess. D, the abscess can be drained by aspiration under ultrasound scan. E, the pus must always be evacuated by incision and drainage in order to cure the abscess. Now, usually, you can go for a non-surgical treatment where you can do an ultrasound-guided aspiration. It minimizes the trauma of surgery for incision and drainage of abscess and all other complications that may be associated by open drainage of that abscess. The contraindications for ultrasound-guided drainage, or where you don't do ultrasound-guided drainage, is one, when you have multiple abscesses. Two, when the abscess cavities are septated. So if you do an ultrasound-guided drainage, you might just drain only one within the septum, within a cavity that is septated. So for that reason, you will do an open drainage. So the most appropriate answer here is abscess can be drained by aspiration under ultrasound guidance. Now, causes of epistaxis include all except A, trauma. Trauma is a very common cause of epistaxis. CSF rhinorrhea is leakage of cerebrospinal fluid via the nostrils, maybe following fracture of the anterior cranial fossa. Okay. No speaking also is a cause of epistaxis. Coagulopathy is a cause of epistaxis. All of the above. Okay. So the most appropriate here. Okay, this is not a cause of epistaxis, rhinorrhea, and all of the above is also not a cause because one here is wrong. So our correct answer here is CSF rhinorrhea. You should know it's not a cause of epistaxis. Now, concerning intersex. A child with ambiguous genitalia should be investigated as an emergency. B, a female pseudohermaphrodite is caused most commonly by androgen resistance. C, Klinefelter syndrome is an example of androgen resistance. D, male pseudohermaphrodites is caused by excessive realization of a female child, commonly from adrenal hyperplasia. E, none of the above is correct. So you can see all these options are not true. This is not an emergency. In fact, counseling and recounseling of the patient is very paramount. And I mark you, sometimes you see cases where a child has already grown. During my pediatric surgery posting, there was a young lady that came, I think she's about 12 years, with ambiguous genitalia. And of course, he's a male. After evaluate, because at that age, he was not growing breasts. And the parents have already raised this child as a female. She was not growing breasts. There was no iota of breastboard at all. Then at ultrasound scan, there was no uterus at all. Okay? So sometimes this is influenced by the sex a parent is interested in. So they will tend to grow that child as that sex. So of course, this child grew, he was 12 years old, and there was no breastboard at all. Scanning revealed no uterus, no ovary. It's just the genitalia that is ambiguous. Okay, so after evaluation, the parents were recounseled again because they came from one remote area. So after counseling, they consented, and this child's external genitalia was reconstructed as a male. And of course, all the attempts to even grow hair refused. So we just removed his hair tie and shaved his hair properly because he was trying to leave hair, and of course nothing was growing. It appeared rough. And later, when we came back, the guy was already putting on a male outfit, and of course he started interacting. But we now told them that his environment, he has to change the environment. Okay, let's quickly proceed and finish these MCQs. Skin cancers can present in the following way: A cystic nodule, B, pigmented lesion, C, an ulcer with sloping edge, D, eczematous lesion, D, none of the above is correct. Now you should know, this, when you see an ulcer with sloping edge, it's more of a healing ulcer. This is a sloping edge. Skin ulcers usually present with an everted edges, or raised a rolled edge, Okay, so that one is false. Concerning immunodetection, antibodies against tumor associated with viral antigens have been found in the following conditions. Now, we are looking for conditions that virus might be an etiological factor. cervical cancer, of course, human papilloma virus, nasopharyngeal cancer, of course, malignant melanoma, Burkitt's lymphoma, osteogenic sarcoma. Now, for all these, viruses have been implicated. So each and every one, you should check the virus that has been implicated. Osteogenic sarcoma is not associated with any viral cause. The following is or are true about liver function. The following is or are true regarding liver function. Now, please, you should know that liver function test is an interpretation of lab results that is commonly seen in an OSCE station. God willing, tomorrow we are going to talk about interpretation of lab results. So the following is or are true about liver function tests in patients with obstructive jaundice. A, serum bilirubin may be normal. B, markedly elevated acid phosphatase. C, markedly elevated alanine transaminase. D, markedly elevated alkaline phosphatase. E, markedly elevated gamma glutathione. Okay, the following is or are true. Now, gamma glutathione is elevated in obstructive jaundice. Alkaline phosphatase is also markedly elevated in obstructive jaundice. Alanine transaminase may be, it may be normal or slightly elevated. It's elevated when patient is already developing biliary cirrhosis. Markedly elevated acid phosphatase. Then bilirubin may be normal. Usually bilirubin is elevated. Total bilirubin is elevated, as well as what do you call it? Conjugated bilirubin. It's both total bilirubin and conjugated bilirubin are elevated. So this one that this option says may be normal except in the early phase, but usually they are elevated. So I think our wrong answer here will be bilirubin, because that is the bottom line of what is elevated. The following statement is or are true, untrue about nephroblastoma. Arises from neurogenic tissue. Is false. It's an embryonal tumor. Yes. Hematuria is an evidence of advanced disease. That is correct. It is common in children during first year of life. That is also correct. Bone and cartilage may be seen in the histology. Yes, it's true, because it's teratomatous in origin. So it's not nephrogenic. Metabolic acidosis can be seen in the following except okay, pyloric stenosis. Pyloric stenosis will cause alkalosis because they are vomiting acid. Okay, they are vomiting acid. So This is false. Diarrhea, they lose a lot of bicarbonates and fluid, so they will have metabolic acidosis, is correct. Diabetic ketoacidosis, they will have bodies which will cause acidosis. Renal insufficiency, also intestinal fistula, will lead to a lot of loss in bicarbonate, which will cause metabolic acidosis. The following are common symptoms of prostatic enlargement, except which is not a cause of prostatic enlargement. Nocturia is frequency at night. Nocturia is frequency at night. It is caused by prostatic enlargement. It's the symptoms. Interrupted urine stream is also an obstructive lower urinary tract symptom. This is an irritative, this is an obstructive. Polyuria, they don't usually have polyuria, it's frequency they have. You see, polyuria is increase in frequency and volume. In BPH, it's only increase in frequency, not the volume. So that is the difference. So C is false. It's not a feature, it's frequency. Increased frequency of maturation. Hesitancy is difficulty in initiating maturation, which is a feature of, what do you call it? BPH. Concerning urethral stricture, choose the best option. Concerning urethral stricture, choose the best option. A, it is most commonly treated by internal ureterotomy. B, frequently present with hematuria. C, commonest cause is instrumentation. D, may present with acute urine retention. E, post-traumatic type is usually multiple. Now, this internal ureterotomy is not the best choice. Urethroplasty is the best treatment of choice. Urethroplasty, not internal ureterotomy. Frequently present with hematuria they don't commonly present with hematuria, so this is false. They rather present with lower urinary tract symptoms, obstructive, predominantly obstructive and irritative. Commonest cause is instrumentation, false. The commonest cause is post-infective, where they have purulent urethritis in the past. Okay, gonococcal urethritis may present with acute urine retention. Yes, they present with acute urine retention. Post-traumatic type is usually multiple. This is false. Post-traumatic type is usually single. Multiple types are seen when it is post-infective. An indication for tracheostomy is A, post-esophageal replacement, false. Advanced laryngeal tumor, of course, when they have laryngeal tumor, they cannot breathe. You just bypass that obstruction. Pterogosal fistula is even above the trachea, false. Tension pneumothorax, no. It's just tube, you pass here. Malignant obstruction of the stomach, false. So I think that is the last question. So we are going to entertain questions. If you have any question, you can unmute yourself and ask, please. Any question? So if there's no question, next we are going to discuss on pathograph, on how to plot a pathograph. So I'm going to contact Dr. Mariam. If she's ready, then we are going to continue. Thank you very much. For now, we'll take a break.
Doctor?
I'll get back to
Okay.
you when I contact her. Yes, any question?
Yeah, doctor, please, I kept on having internet interruption. I missed some of the questions. Can you please send us the slides?
Yes, it's being recorded. You can go through
Oh,
all,
okay.
and also I'll send you the slide. It's being recorded.
Thank you. Mm-hmm.
Okay. So next, I'll inform you when she's ready on the group, on when we'll start the discussion on pathograph. Thank you all.